Thank you very much for taking the time to join today. My name is again Hilal Atasoy. I'm a new faculty member at Rutgers University. Today you will be hearing from me 2 times, and both papers relate to the impacts of electronic health records. One will focus on the effects of decision making and racial biases, and the other one will focus on effects on reporting and reimbursement revenues. So first I will talk about the role of decision support systems in racial biases in healthcare. And this is a joint project with my co-authors, Kartik Ganju from McGill, Brad Greenwood from George Mason, and Jeff McCullough from University of Michigan. So racial bias is an important and widespread problem that exists in different parts of the economy. For example, equally qualified African Americans are less likely to be called back for job interviews, and they receive smaller raises for equivalent work, indicating that they face significant barriers in the labor market. Similarly, in the judicial system, African Americans are more likely to face higher charges for similar types of crimes. And these racial discrepancies are relevant and quite prevalent in the healthcare system as well. Black Americans have lower life expectancy and worse healthcare outcomes on average. And these differences in health outcomes between races have raised obvious questions about how differences in healthcare provision might contribute to these patterns. So there's a big literature on this topic. And just to name a few here, Black patients are less likely to be selected for transplants. They survive major life-threatening episodes less, such as a cardiac arrest. Black women survive childbirth less. They also receive fewer high-cost surgical procedures that can be life-saving, such as a coronary artery bypass. So something important to note here, right, these differences that the literature is documenting are not explained by differences in patients' clinical situations or other observed characteristics such as socioeconomics and insurance coverage. So in this paper, we analyze the effects of digitization on biased decision-making, and we're looking from an angle of digital protocols. So the use of digital protocols and checklists can standardize the decision-making process because these protocols create a structured information gathering steps and enforce certain decision rules along the way to make sure all the users are adhering to these consistent steps and guidelines. And we can think that these digital protocols can be especially important in a context like healthcare, where decision-making is inherently complex and subjective, especially when it comes to complicated cases. And when we look at the literature, we see some evidence of benefits of digital protocols in this context. Surgical checklists can increase the efficiency of life-saving procedures and decrease the error rates, and can increase overall adherence to best practices in healthcare. So we expect protocols and procedures to formalize decision-making steps and reduce the subjectivity and bias along the way. And the specific bias or racial discrepancy we're focusing on in this paper is about patients with peripheral vascular diseases. So this disease is caused by blocking and narrowing of blood vessels in extremities, such as foot or leg. And to a large extent, this disease is associated with diabetes because diabetes patients have a higher likelihood of developing blood clots. So this restricted blood flow into the leg or foot, into the limb, then ultimately can lead to tissue death, gangrene, foot ulcers. So these are patients who already have some sort of complication in their foot or leg and go to the hospital looking for treatment. So it's a specific type of group where we are focusing on because they face basically 2 treatment paths. One of them is revascularization. So revascularization is a procedure or a surgery where physicians rebuild the veins and arteries to increase the blood flow to the tissue so that the foot or leg, the limb, is saved. And the other option is amputation. In this case, the limb is removed to stop the tissue decay and the spread of the infection to the rest of the body, which can be deadly. So a striking racial disparity that has been very well documented in the medical literature is that Black patients are more likely to receive an amputation procedure while white patients are more likely to receive a revascularization procedure. And again, in this literature as well, these differences persist after controlling for the current situation of the patient, which probably is the most important determinant of the treatment course, right? How bad the gangrene is when they go to the hospital. Other types of comorbidities, chronic diseases they might have, and that can again affect the treatment course or the sensitivity to different types of medication, their sociodemographic factors, and their insurance plan. After accounting for all these factors, the literature still shows that Black patients receive on average more amputation procedure compared to the white patients. And I think we can agree that amputation is undesirable for the patient if other options are available to the patient, because it causes permanent damage to patient mobility, and it is not easy to lose your leg or foot. It changes your whole life. So it has a significant psychological harm. It is also costly to provide services to facilitate the mobility after the amputation surgery. So overall, right, for the patient, the desirable option is to receive a revascularization surgery, but this doesn't mean revascularization is always the right decision, because in severe cases, amputation might be inevitable and necessary for patient survival. And if a patient who's supposed to receive an amputation receives failed revascularization, this can only prolong, right, the suffering that goes to the eventual amputation, maybe creates more complications and increases the severity for this patient's situation. So overall, this amputation versus revascularization decision is known to be a complicated one, because physicians need to control several factors. The extent of the gangrene, right, the current clinical situation of the patient is probably the most important factor that determines the treatment. And revascularization surgery requires extensive follow-up care. So here, right, the insurance plans and access to care comes into play. Of course, the general condition of the patient, but other types of diseases they might have, all these play into the decision-making process. And this complexity that includes both clinical and the social factors can lead to subjectivity in this decision-making. So in this paper, we focus on the role of clinical decision support systems, a particular EHR module, electronic health record module, CDSS. So this system creates a digital index of patient characteristics, and they can also generate patient-specific recommendations to the physicians for the treatment course of action. And the unique aspect of CDSS within the other electronic health records is that they have the capabilities to implement care protocols and standardize care procedures. So the digital protocols into the healthcare or electronic health record context is implemented through this system. So our research question is, we're asking, what is the effect of CDSS adoption on amputation rates for Black versus white diabetes patients? So if you think about how can these systems impact decision-making process and reduce bias, we came up with two major mechanisms based on our interviews with physicians, as well as review of the medical literature. One of them is these protocols can standardize the diagnostic tests and procedures patients should receive. So for example, one of the doctors that we talked about this issue, which also implemented these digital protocols in a major US hospital, said that in case of patients on the margin between amputation and limb preserving procedure, which is revascularization, protocols mandate tests that can allow physicians to make an objective call which procedures should be conducted. So the protocols impose these tests and diagnostic procedures onto physicians in certain cases, and they cannot complete the decision-making process without having that additional information. And actually, in our data set, we see an increase in these diagnostic tests and procedures after CDSS adoption. And the second main mechanism is that these protocols can increase the probability that specialists are involved in the care team. So it has the capability to change the ultimate care team the patient is facing. And in our context of vascular diseases, revascularization specialists can provide more informed and objective information about the potential success of the revascularization surgery. They might have more extensive experience about the topic, so they can bring in additional important information. So again, another doctor, we talked about it, said that, so if you think about a patient who's admitted with a gangrene in his or her foot, with protocols, the admitting physician will need to wait until the revascularization specialist gives their opinion and the decision to amputate will be made. So both of these mechanisms, increasing or enforcing diagnostic tests and procedures that patients should receive, as well as creating this better care coordination across specialists and clinical experts, can increase the amount of unbiased information and reduce the ambiguity in the decision-making process. And if, in fact, the racial discrepancies, differences we see in amputation rates is due to subjectivity of the caregivers, we expect these types of protocols to reduce these biases, at least to some extent. So to test this, we combine data from several sources. So our patients level data comes from HCUP between 2006 and 2013 from 3 major states. So we have universe of all inpatients. We observe all their visits. We can track them over time. We know their diagnosis codes. We know what procedures they have gone through. We know their key sociodemographics, in this case, race, age, and gender, and we know that their insurance plan. Our health IT data for the hospitals comes from a database called HIMSS database in short. So this is a very commonly used and the most comprehensive database in the US that's tracking health IT adoption and use of hospitals. We also get some hospital level controls from Medicare cost reports. So we are focusing on specifically on patients with vascular diseases. So this corresponds to more or less 10 diagnosis codes. So these are patients with peripheral circulatory disorders, lower extremity, arterial stenosis, so on and so forth. So there are about 9 or 10 diagnosis codes that correspond to the vascular diseases. And these diseases, again, correspond to 2 types of procedures that patients can have. Again, we here have about 10 procedure codes, but they can be generalized in 2 major categories: amputation, versus revascularization. And we remove patients from the data set who are not Black or white. So we observe the race in the HCUP data set. We remove the other races just to have a more clean empirical setting and to be able to compare our results to the previous literature. So in our empirical specification, our main dependent variable is the amputation. So this is a binary variable that's equal to 1 if patient I received an amputation procedure in hospital J at a particular year, and it's going to be 0 otherwise. So we look at the CDSS adoption of the hospital, if CDSS was in use and active in hospital J at year T. So one of the major coefficients of interest for us here is beta 3, the interaction between CDSS and Black. So if these systems change the amputation rate for Black patients differently compared to the white patients. So we do an estimation of the severity of the patient. I will get into, talk a little bit more about that in the next slide. We have some patient level controls, their age, gender, insurance. We include hospital fixed effects and year fixed effects. So in terms of severity estimation, it is important to accurately account for patient severity, not just because it's the most important determinant of the course of treatment, but it might be also correlated with race. So if Black patients are going into the hospital in a more severe condition, that can explain some of the differences in the outcomes, right, in the treatments they are receiving. And one challenge here is that this severity measure and risk factors are multidimensional, and they include medical, clinical information, as well as other types of sociodemographic factors and insurance information. So here we use a machine learning approach and use random forest classification to come up with a severity index. We use about 30 variables here to come up with one single index of severity for the patient, basically their propensity to be amputated. I won't get into the details for this severity estimation for the sake of time, but I just want to mention that it actually doesn't matter if you use machine learning or if you just toss all these 30+ variables into the regression, results are robust to alternative ways of modeling the severity. So once we get the severity estimation, we plug it in here into our regression. So before getting into the main results, so I want to talk about some endogeneity challenges and the robustness tests we have done, just particularly because I won't have time to present them, but I will briefly mention them. And if there's a particular question about one of them, I can get into it. So the main identification here is coming from within hospital changes in CDSS use and their amputation rates across Black and white patients over time. So our main identifying assumption here is the parallel trends assumption, that these hospitals that adopt CDSS were not on a different trend in terms of their amputation rates across races compared to the hospitals that did not adopt. So we use a relative time model to test this pre and post adoption trends. We do not find any significant pre-adoption trends leading up to the adoption. We further control for hospital-specific time trends and other hospital time variant characteristics. We also test if the patient pool is changing over time, if the severity of these vascular disease patients are changing over time, because if so, that could explain some of the results as well. We do not find any evidence that the patient's pool is changing over time. We do a pseudo treatment test for serial correlation of errors because our each observation patients are repeated within the hospitals, and there might be some correlation in decision making within these healthcare organizations. We also remove returning patients because we see several patients coming back for multiple revascularization surgeries, and the information gathering process and perhaps the decision making process for physicians can be significantly different for them. So we remove them to make sure the results are robust to that. And then we check a bunch of different types of nonlinear specifications, try different ways of modeling severity and different subsamples, and the results remain robust. Okay, so I'll jump into the main results. So here, the first thing I want to take your attention is the coefficient on Black. So we find that Black patients are 8.3 percentage points more likely to receive an amputation procedure, again, controlling for all these factors. And the average amputation rate in the sample is 22%. So this 8 percentage points correspond to Black patients being 36% more likely to receive an amputation surgery on average. And if you look at the interaction between the CDSS and Black, we see that CDSS adoption that implements digital protocols into the decision-making process reduces this difference by half. And we do not see any effects on the baseline group, which is the white patients group. So no effects for the white patients. And in the second column here, then we just condition on the Black patients, removing the white patients. We again find a similar coefficient magnitude of 4% decrease, 4 percentage points decrease in the amputation rate. So if you look at the relative time model with pre and post adoption effects, we see that all the effects of CDSS adoption accumulate after post adoption years and on Black patients, no effect for white patients, and no effect for years leading up to the adoption for Black patients. And if we were to visualize this coefficients, we see that for white patients, we do not see a changing trend, right? Their amputation rate remain constant. And for Black patients, again, we do not see a statistically significant difference before adoption. And the year after adoption, we see a 4 percentage points decrease, and that remains stable after the CDSS adoption. So an important thing to consider here is that what if, right, these increased revascularizations that Black patients are getting simply delaying the eventual amputation, right? If it was the wrong decision to revascularize these patients, and if these procedures are followed by increased amputation rates into the future, right, this would suggest that CDSS systems not only lead to these unnecessary procedures, but might be putting patients at risk, right? Because they might have further complications by delaying the needed amputation. So here we test the long-term dynamics, and we take a look at the patients who received a revascularization procedure at year T, and we track them over time and see if they receive a future amputation after that year. So here we do not find any significant effects. So these patients who receive the revascularization surgeries are not getting amputated down the line a few years later. So indicating the revascularization decision for Black patients that CDSS is enabling is the long-term beneficial decision for these patients. So another thing we tested here is, are the effects heterogeneous by patient severity, right? Because in terms of the ambiguity of the decision making, in severe cases, we know that amputation is inevitable and probably necessary for patient's survival and patient's overall health. And if the case is so easy, right, so minor, the decision to revascularize would be easy to make as well. So we expect the action happen to this in the middle ground for the marginal patient who can go either way, right? So between a amputation and a revascularization surgery. So here we test the effects of CDSS by looking at the distribution of the severity, and we divide the severity in quintiles, 5 points in the distribution. And for the patients in the baseline category, these are the patients that have the lowest severity, we see no effect. Similarly, for the second quintile, we do not see any significant effect. When we look at the patients who are most severe, again, we see no significant effect. So the effects are accumulated for these patients who are in the middle of the distribution of severity. As we expected, the impacts of CDSS on decision making is more important when decision making is more ambiguous for the marginal patients. Okay, so then I think I will just wrap up here and leave the rest of the time for questions and discussion. So we find that digital protocols and guidelines have the potential to structure decision-making process and reduce undesirable biases. And when we look at the literature on impacts of electronic health records and digitization, we find many papers that showing they improve care quality, including CDSS or other types of health IT systems. So here in this paper, we are showing it's not only improving the overall care quality, but also reducing the discrepancies in care provision across groups. And of course, these results have important implications for patients because they directly affect, right, the course of treatment for them, but it also have implications for healthcare organizations because these types of protocols might help them make better decisions and limit their legal liabilities that happen a lot, especially in the US, associated with heterogeneous treatment. And policymakers can overall aim at enforcing these protocols to standardize care procedures and reduce the biased care. I will end with that. Thank you very much.